Okay, everyone, as you all join us from around the world, it's a delight to have you all here. My name is William Dillon, Dr. William Dillon in San Francisco, and I'm a co-founder for Health for the World, and we're just absolutely delighted to have Dr. Jenny Bencardino, who is the Chief of Musculoskeletal Radiology at the University of Pennsylvania, presenting this morning on MR Neurography of the Lumbosacral Plexus. And this is a particularly interesting to me because we have been doing a lot of neurography at UCSF, and as it has developed, I get, as a neuroradiologist, further and further away from the brain and more towards the fingertips. So I'm really looking forward to this presentation. Dr. Bencardino started her academic career as an assistant professor of radiology at Harvard Medical School and was promoted to full professor of radiology and orthopedic surgery at NYU School of Medicine in 2014. She's currently chief of musculoskeletal imaging and professor of radiology at Penn Medicine. She does have a hard stop today, about 1:45, so I'm going to turn it over to her now. And thank you very, very much for your time and presentation today, Dr. Bencardino.
Thank you so much, Dr. Dillon. It's my pleasure to be here. You certainly have made a wonderful project out of Health for the World, and I'm honored to now be part of it. So let's start with MR Neurography of the Lumbosacral Plexus. I have no disclosures to make. Nerve impingement syndromes are rather challenging. It's a challenging diagnosis both for radiologists and clinicians alike. We need to know the very complex neural anatomy and innervation patterns in order to arrive to a correct interpretation of nerve imaging studies. Nerve impingement syndromes can occur anywhere in the body, but they tend to happen more commonly in areas where there are fibro-osseous channels near joints. So we see compressive neuropathies more commonly in these locations. And if there is a fibrous band or an accessory muscle that may cause occupy space, then there is going to be more propensity to have a compressive neuropathy. Of course, the space-occupying lesions near joints, we often find ganglia, hematomas, osteophytes, lipomas, tenosynovitis may also cause mass effect and lead to compressive neuropathies. There are other types of entrapments that have to do with dynamic compression, and those are related to joint motion. So typically carpal tunnel syndrome, repetitive flexion and extension at the level of the carpus is going to lead to entrapment of the median nerve. Same thing with the ulnar nerve in the cubital canal in the elbow. So these are dynamic entrapment neuropathies. The reference standard for diagnosis of entrapment neuropathies is clinical diagnosis, although it can be challenging, particularly if the nerve that is entrapped is deeply situated in the human body, and electrodiagnostic studies. I am a person who underwent EMG study once in my life. I do not recommend it. It's painful, so it does cause patient discomfort, and it may lead to inconclusive results in up to 1/3 of cases. So it is not really a gold standard. And on MRI, nerve entrapments are manifested depending on what sequence we are assessing. So if we are looking at T1 and non-fat SAT proton density sequences, nerves are going to behave very similar to muscle. So muscle is going to be your standard to compare to. We have here the division of the sciatic nerve into the common peroneal nerve and the tibial nerve in the distal thigh. And you can notice how there is this intermediate signal intensity quality to the nerve fascicles, very similar to muscle. The human body was built in a very wise way, so nerves tend to be surrounded by fat. Fat that protects the neurovascular structures from being damaged. That fat on T1 radar images is bright, so it provides a beautiful backdrop of bright and intermediate signal so that we can better outline nerves on anatomic sequences. Now, on fluid-sensitive sequences, nerves tend to have a little bit of increased signal intensity, and we need to learn how to interpret this increased signal intensity. So for entrapment neuropathies, we want to see focal areas of increased T2 signal within the nerve fascicles at the site of entrapment. So we want to see that high signal intensity where the ganglia is located pressing on the nerve. We want to see the high signal intensity within the cubital tunnel or within the carpal tunnel. We don't want to see just a slightly increased signal intensity all throughout the course of the nerve. That is going to be just the normal appearance of the nerve on fluid-sensitive sequences. Entrapped nerves tend to show changes in signal intensity, size, and position. So that's to keep in mind. What are we looking for? We're looking for changes in the signal intensity, the caliber of the nerve, and the course of the nerve. Those are direct signs of entrapment neuropathies. We have also indirect signs of entrapment neuropathies, which we call muscle denervation changes. So denervation changes are going to help us because nerves that have motor components are going to lead to a muscle group, and that muscle group is going to get changes on T1 and T2 weighted sequences. So typically, edema-like T2 hyperintensity is seen in the earliest stage of nerve entrapments, and then progressively we're going to have fatty infiltration that may lead to a complete replacement of the muscle by fat. So acute, only edema-like changes, bright signal on fluid-sensitive sequences, subacute, a combination of edema plus fatty infiltration, and chronic, we're going to just see the fatty infiltration and the loss of muscle bulk. Technical considerations, we want to do MR neurography, and in this case, I'm going to talk about the lumbosacral plexus on a 3 Tesla magnet. So if you have a 3 Tesla unit, we prefer to book the patient to have the study in that magnet. Why? Because we want to play with increased SNR. We want to have higher spatial resolution, thinner slice sections, increased fluid conspicuity. We want to play with parallel imaging to do faster acquisition and prevent that motion may limit evaluation of nerves, and particularly small nerves, so we want to do it fast. And we also want to suppress the adjacent vessels, and we can do all that on a 3 Tesla platform much better than on a 1.5. However, there is exception to these scheduling rules. So our schedulers, when they pick up the phone and, oh, it's MR neurography of the lumbosacral plexus, they have to ask if the patient has hardware in the field that is going to be imaged. If there is hardware, that patient must go to a 1.5 Tesla magnet because the susceptibility artifact from metal in the field is going to cause so much distortion that we won't be able to see the nerve. So that's the exception to the scheduling rule. Another important factor is the time of the day when you do the study. So I like to book my patients early in the morning, have them go to the bathroom for sure before they go to the magnet so they can avoid the bladder. Full bladder can cause ghosting artifact, as you see here, and also have them NPO. The reason for that is that decreases bowel movements, and bowel movements can also cause distortion on MR neurography of the lumbosacral plexus. Find your B-value. That's really important. When I started the program of MR neurography at NYU in 2013, I was inspired by Dr. Avnish Chabra, who has become, the king of MR neurography. And he very selfishly lent me all his protocols. So I started playing with the protocols, and I invited him to spend a week with us to check our program. And when he came to say, oh, your sequences are prettier than mine now. So that's good when we collaborate with other people, when we are not selfish, when we are, want to advance patient care everywhere, not only in our institutions, is a beautiful thing. So we play with the v-value, and the v-value that works best at 3 Tesla for the PSIF sequences, we decided that is 80 milliseconds. I will go into the sequences just in a second. Coverage. So we want to cover the roots of the lumbosacral plexus. We include from the mid-level of L3 all the way down to the lesser trochanters. So that's the craniocaudal dimension. On the mediolateral dimension, you want to include the muscles. So you see how I'm making sure that I'm including all the gluteal muscles in the field of view. And then here on the coronal sequences, you see the extent of the craniocaudal coverage from L3 to the femoral proximal femur, the lesser trochanters. So this is what we're seeing, the root of L3 coming out here under the L3 pedicle, the root of L4 being highlighted by fat in the paraspinal region. Now, we also at the beginning had to play with what are we doing for fat suppression, and we play with selective fat satin, and we didn't do that well. We actually don't do selective fat sat in the pelvis anymore. We do a combination of a stir and a selective fat suppression. So the Siemens platform that I use to do MR neurography has a spare, which is a combination, and it provides a very homogeneous. You can see the difference between selective fat satin with large field of view in the pelvis against a spare sequence where everything is more homogeneously decreasing signal intensity where there is fat. There are 5 sequences that we include for TMR neurography. One high-resolution axial T1, and we have an example here of how the images look like. We are taking advantage of the fat, highlighting nerve fascicles. So you can see here the obturator nerve divisions, anterior and posterior, just proximal to the obturator foramen. Axial T2 is spare, and this is a 2D sequence. So 2D axial T2 is spare. We have very nice, fat suppression across the field. Coronal proton density, and I like to do it with a high resolution technique as well. And again, we are taking advantage of the fat. We can see very nicely the obturator nerve coming down here in the pelvis. So check that obturator nerve. You're going to see it in every patient if you look for it. And then we do 2 3D sequences, one a space stir sequence, and 2 a coronal 3D DW-PSIF for reverse fast imaging with a steady state free precession. This is an example of the 3D spaces per T2 sequence. This is done at 0.8 millimeter cubic, so really, really thin slices. And this is my very first patient at NYU in 2013. This patient had a foot drop following, unfortunately, a drug overdose. The patient was lying on the floor of his apartment for more than a day. Apparently, he was lying on his right buttock. And when he woke up, he had a foot drop. And we can see when we compare side to side the right sciatic nerve against the left sciatic nerve, the right sciatic nerve is increasing caliber, is almost twice as big as the left-sided sciatic nerve, and is also increasing signal intensity. So on spare images, we're looking for this intraneural increased signal intensity, which have vessels nearby. We can compare whether the signal intensity is less or equal to vessel. Definitely, if a nerve has equal signal intensity to an adjacent vessel, is completely abnormal, is increasing signal intensity. And this is the PSIF sequence, also 0.8 millimeter cubic. You can see the piriformis muscle coming through the greater sciatic notch. And then on this patient on the right side, comparing the right sciatic nerve against the left sciatic nerve, we come to a point where the fascicles, you can see here the fascicles, there is a pinpoint area of increased signal intensity within the nerve fascicles. There are no vessels here. We are suppressing the vessels, and it's right under the piriformis, the inferior edge, and also at the border of the superior gemellus. So in this space between the piriformis and the superior gemellus muscle is where we see entrapment due to mechanical impingement by the piriformis. In this case, the piriformis wasn't increasing in volume. It was just that he was lying on that side, pressing on the nerve for a prolonged period of time. And these are the reconstructions of the 3D space sequence. We can see on the right side, this is the right sciatic nerve, left sciatic nerve, and we can see the difference in caliber of that right sciatic nerve. And here, just to emphasize, why do we do two 3D sequences? We do a 3D sphere sequence because we want to have the nerves, the nerve signal adjacent to the vessels, and so we can use the vessels as a comparison. And then the PSIF takes away all the busyness of the nerves and let us concentrate on the nerve fascicles themselves, so our eyes can pick up increased signal intensity within the fascicles themselves, as we can see here. Something cool that we can do, and surgeons get very impressed with these movies, is we can do movie reconstructions of these volumetrically acquired images. All right, so let's move on to the anatomy of the lumbosacral plexus. The lumbosacral plexus has main branches. The sciatic nerve is one of them. The sciatic nerve has a tibial division and a peroneal division. The tibial division is medially located. The peroneal division is laterally located, and we'll go deep into the sciatic nerve in just a second. The femoral nerve, I like to find the iliacus muscle, and then the femoral nerve is going to be over the iliacus muscle in these 3D mid reconstructions. When you are playing with the images, check for your iliacus muscle, and then you'll find the femoral nerve right next to it. The obturator nerve is the one that has the straighter course, so just check the paraspinal region and the nerve that you see coming down very squarely and straight, and that's the obturator nerve. It tends to go along the margin of the psoas too, so the psoas muscle is a good parameter, anatomic parameter to find the obturator nerve. Let's move on to the greater sciatic notch. So now we're going to get into the sciatic nerve. In the greater sciatic notch, we have the piriformis muscle. The piriformis muscle exits through the greater sciatic notch from the pelvis into the gluteal region, the posterior hip, and it divides the greater sciatic notch into suprapiriformis and infrapiriformis notch. The suprapiriformis notch is the house of the superior gluteal neurovascular bundle. So you can see the superior gluteal neurovascular bundle there. And the infrapiriformis notch is where we are going to find the sciatic nerve. So we have the sciatic nerve seen here, outlined by fat, as it goes under the piriformis and about by the gemelli muscles. In the sagittal plane, we have a similar distribution here. You can see the localized image, piriformis muscle, and then sciatic nerve just beneath it. So the sciatic nerve is the largest nerve in the body. It's termed the lifeline of the lower extremity. So this patient who unfortunately had a drug overdose and woke up with a foot drop, you cannot move your lower extremity if your sciatic nerve goes. So surgeons want to preserve it. We want to preserve the sciatic nerve, so it's a very important anatomic structure. It receives contributions from L4 to S3. is composed of two distinct divisions, and these drawings were made by a visiting fellow from Spain. She's now actually in England, and she's of Colombian background, so she combined what this is really meant to be about, right? An international, global community sharing knowledge and helping each other to advance medicine. So the tibial division here is painted in green, and the peroneal division is painted in purple, and is laterally located. In terms of functionality, the sciatic nerve is responsible for knee flexion because it innervates the posterior thigh muscle. So the hamstring musculature is innervated by the sciatic nerve. The tibial division is going to do most of the hamstring muscles. The peroneal division only innervates the short head of the biceps femoris in the back of the thigh. Below the knee, it provides all sensory and motor functions except for the innervation of the medial leg, ankle, and foot, which is provided by the saphenous nerve, the terminal branch of the femoral nerve. Clinically, when there is a sciatic neuropathy, we frequently see a spreading of the hamstring musculature, and we're going to see that the process affects the muscles below the knee level. It more commonly affects the peroneal division with relative spreading of the tibial division. And this is due to the fact that the common peroneal nerve is fixed at 2 points. So when it goes by the ischial tuberosity, it's kind of tented there. We're going to see some examples. And then it goes obliquely towards the side of the knee by the fibular head, so that the fibular head and the ischial tuberosity fix the common peroneal nerve in 2 points and make it more susceptible of a stretch injury. And it's also more superficial, so that's the reason why the common peroneal nerve gets more affected. The course of the sciatic nerve in the pelvis, we already saw it, goes anterior to or through the piriformis muscle. Here is the reconstruction. That's the piriformis muscle here. That is going to exit the greater sciatic notch or sciatic foramen under the piriformis, and is going to go by the superior and the inferior gemellus, the gemelli muscles. Then we have the quadratus femoris, number 3 here, and the obturator internus, which is probably part of this muscle mass in this location. Then it's going to continue down to the thigh, and it's going to divide into the tibial and the common peroneal nerve in the distal thigh. In the pelvis, what we do on the coronal images is that we want to find the sciatic nerve as it gets formed in front of the sacrum. Then we identify the piriformis muscle right there. We have the sciatic nerve going under the piriformis muscle. Then we get to the greater sciatic foramen, and we have the superior gemellus and the inferior gemellus muscle. Then we have the obturator internus, which helps me a lot in the axial plane. We'll see that in a sec, and the quadratus femoris right there. The ischial tuberosity is a very important structure also to keep in mind. So we see it here, and you can see the origin of the hamstring tendons is nearby the sciatic nerve. So all those structures are very important when we are assessing the sciatic nerve at the level of the pelvis. And this is what I meant. I like to, in the axial plane, I find the obturator internus muscle, and then right at the posterior border of the obturator internus muscle, you are going to find this little fascicular structure. This is the sciatic nerve. So it's normal to have fat between the fascicles of the sciatic nerve. The size of the sciatic nerve can be up to 2 centimeters in width. The key element about the fat between the fascicles is that it should not disturb distort the fascicles. So it shouldn't have mass effect. It should be just, lying nice and quiet in between the fascicles without causing any displacement. And the fascicles are going to have intermediate signal intensity, as we already say, similar to muscle. Here in the coronal plane, origin of the hamstring, sciatic nerve, tibial division medially, laterally we have the common peroneal nerve division. And this is in the axial plane. The piriformis is going to be located posteriorly, and the sciatic is going to be lying on top of it. Okay. Now let's go into pathology. There's sciatic neuropathy. The key elements that we are looking for, I already mentioned, increased signal intensity within the nerve, thickening of the nerve, and course deviation. So this patient has sciatic neuritis, is just increased caliber and signal intensity, T2 signal intensity in the nerve, in this stretch located between the greater sciatic notch and just by the proximal portion of the hamstring tendons. So this was just sciatic neuritis. Sciatic neuropathy can also be seen in the setting of neurofibromatosis, but this is really, outside of the scope of this talk, but just wanted to show you how the nerves are going to be distorted by the neurofibromas in this condition. This is a case of sacral osteomyelitis, and this patient developed abscesses that were extending through the greater sciatic notches. There is an anatomic bursa about the piriformis muscle, the piriformis bursa, which may get distended. I speculated that that was the case in this patient, where we have these very large fluid collections that are very well encapsulated and defined in the region of the greater sciatic notch. So the patient was having symptoms of sciatica more on the right side because the abscess was much larger on that side of the pelvis. This is relatively often seen, unfortunately, in patients who have hamstring tendon repair. This patient had undergone a repair with a surgical anchor. We can see the anchor suture right here within the ischial tuberosity. And the patient developed these adhesions between the surgical device and the sciatic nerve. So the sciatic nerve was being, you can see the change here in the sciatic nerve. It was being tented by these adhesions between the surgical anchor and the nerve, and the nerve is markedly increased in caliber, and this patient had a foot drop. So she had to go to surgery. Surgical scar tissue was found in between the nerve and the ischial tuberosity. They did an adhesion lysis. They got rid of the adhesions that they found there. And she, I saw her at least 3 or 4 times, unfortunately, develop fatty atrophy of the sciatic nerve fascicles and never went back to normal. Piriformis syndrome is most well known as sciatic neuropathy. The etiology is primarily due to loss of sciatic foramen volumen. There is something occupying the greater sciatic notch, and in many instances is the piriformis muscle itself that may be hypertrophic. So some people may have a bigger piriformis muscle on one side. However, a bigger piriformis muscle is not always causing piriformis syndrome. So you want to see the larger muscle plus the signal changes in the nerve in order to call piriformis syndrome. Trauma, patients who have, for example, I had a patient who fell off a horse and had a hematoma of the piriformis muscle with entrapment of the sciatic nerve. That's another cause. Inflammation, we just saw the case of sacral osteomyelitis with abscesses in that location. local ischemia, intramuscular course. We're going to talk a little bit about that. And compression of the superior gluteal nerve can give very similar symptoms to piriformis syndrome. So this neurovascular bundle here, if the entrapment is up in the suprapiriformis notch. Piriformis syndrome is a diagnosis of exclusion. So these patients have sciatica. They have typically undergone a lumbosacral spine MRI that is completely normal or the findings don't explain the sciatica. And then the clinical presentation is sacral or gluteal pain, tenderness over the piriformis muscle, which is aggravated by sitting, squatting, or walking, and relieved by lying supine. And if any of you listening to me, if you have had a disc herniation, you know that lying supine is not easy when you have a disc pressing on your radicular on a radicular structure on a root. So this is the difference between in the clinical presentation. Piriformis syndrome tends to be more, the symptoms tend to be aggravated by sitting and squatted rather and relieved when the piriformis is relaxed in the supine position. Neurological deficit is infrequent. Well, we may have decreased ankle reflex and knee and hip flexor weakness and numbness. Here. Oh, I grabbed something, the annotate function. Okay. Now, what do I do? Okay. All right, so now this is an example of a split piriformis. The sciatic nerve is going intramuscular within the piriformis. This is a PSIF sequence. You can see that it's not all the nerve going within the muscle, is the peroneal division. So the peroneal division is running intramuscularly, and that was causing sciatica on the left. Look at the nerve comparison side to side, lower down by the gemelli muscle. So the left-sided sciatic nerve was twice as big as the right-sided sciatic, and the patient has symptoms on that side. So this peroneal division intramuscular course can actually cause piriformis syndrome. This is a case of piriformis syndrome due to a space-occupied lesion. This was a paralabral cyst that decided to go rogue and went into the greater sciatic notch. It happens sometimes, and the neck of the paralabral cyst could be seen right here. It was coming from the posterior superior labrum, right hip labrum. And it was causing significant mass effect. You can see the cyst right there, entrapping the sciatic nerve against the piriformis muscle. Let's move on to the femoral nerve. The femoral nerve receives contributions from L2, L3, and L4. It supplies all the anterior thigh muscles except the tensor fascia lata, and it gives sensory innervation to the anterior and distal medial thigh, anteromedial knee, medial leg, medial ankle and foot, so all along the course of the saphenous nerve. On MR anatomy, the nerve is really difficult to visualize in the pelvis because it runs sandwiched between the psoas and the iliacus, and those two muscles are huge. So who is going to see the little femoral nerve in between those two guys? But now we can see it thanks to PSIF, and I'm going to show you that. Once we get to the femoral triangle, the nerve is going to be seen lateral to the femoral artery and vein. We have it here, and it has a fascicular pattern too. So it's similar to the sciatic nerve, where you can see fascicles with fat interspersed between them. And these are intermediate in signal intensity. This is just another presentation here of the femoral nerve, just lateral to the femoral vessels. And this is what we do with the PSIF sequence. We can track the structure painfully 0.8 millimeter by 0.8 millimeter slice, and then what we do is we reconstruct those points, and you can see that's the femoral nerve. Now we can visualize it in the pelvis as it goes in between the psoas and the iliacus. In the pelvis, the femoral nerve is located under the psoas and over the iliacus. When it gets to the inguinal ligament, it goes under the inguinal ligament, and then in the femoral triangle is lateral to the femoral vessels. I thought this case is nice because it illustrates, it's a schwannoma that illustrates the location of the nerve. So you can see the psoas here, the iliacus there, and the mass in between the two, with the typical target sign of a peripheral nerve tumor. And these are the T1 weighted images, also just demonstrating the anatomy of the femoral nerve. Psoas muscle here, iliacus there, and then you can see the schwannoma in between with enhancement on post-contrast images and the nice tail sign of peripheral nerve tumor. This is a case that retrospectively I found the femoral nerve, and I was very happy to do it. So this patient has a tear of the iliopsoas tendon from the left septrocardial, avulsion of the iliopsoas tendon. When the iliopsoas gets upset, and I have to say I got a call this morning at 6 o'clock in the morning by Eric Hume. He runs the hip prosthetic program at Presbyterian across the street from my office. And he wanted me to give him a report on MRI in a patient with a hip replacement who had iliopsoas infectious bursitis due to an infected, unfortunately, hip prosthesis. So very similar to what I'm showing you here, but this was traumatic. Dr. Hume's case, patient was post-operative, hip replacement. So the arrows pointing to the femoral nerve outlined by fluid in between the iliacus and the psoas, and this is the tear of the tendon with retraction and formation of a hematoma with fluid seeping along the course of the psoas and the iliacus into the pelvis. So causes of entrapment of the femoral nerve in this case would be hematoma of the iliacus and psoas. That's a very common cause. Iatrogenic, traumatic gunshot wounds, lacerations, distended iliopsoas bursa, and pseudoaneurysm of the iliac vessels. The obturator nerve, let's move on to that structure. It has contributions from L2, L3, and L4. It fuses with the psoas major muscle along its medial margin, emerges medial to the psoas, and is going to descend medial to the iliopectineal line. So right here it's coming down this way, and then it's gonna go into the obturator foramen and splits into the terminal branches right proximal to it. Even this, thinnest person in the world has some fat in the pelvic cavity. So I'd say everybody has a visualizable obturator nerve. So you can see the obturator nerve in everyone. You just need to look for it. So look for that vertical structure in the paraspinal soft tissues, extending from L2, L3, and L4. And this is just to show the anterior and posterior divisions. The nerve splits into those two, just proximal to the obturator foramen. This patient unfortunately had lung carcinoma with a metastatic focus to the right acetabulum, and that was causing entrapment of the obturator nerve, giving the classic denervation pattern of obturator externus and adductor muscle denervation, edema, light change of obturator neuropathy. We also see obturator neuropathy in post-op cases, very often major pelvic procedures such as total hysterectomy for endometrial cancer, orthoral prostatectomy for prostatic cancer. This is a patient who had undergone hysterectomy, and we can see how the right-sided obturator externus and adductor musculature are decreased in size. There is fatty replacement and also loss of bulk. And then on fluid-sensitive sequences, you see the typical denervation pattern of muscle, where the muscle is bright, and it's almost as if you ask a very keen child to color in the muscle without going outside of the borders, right? That there are kids who do that, who can do that. They just stay within the margins of the muscle. Denervation does that. It stays within the margins of the fascia. You don't want to have any intermuscular fluid. You don't want to have any fascial thickening. You don't want to have any fascial edema. It's just the muscle that is brighter as compared to the other adjacent muscles. Probing into this patient, we found the culprit. The culprit was scar tissue right here in the obturator foramen that was stenting the branches of the obturator nerve. So sometimes we get lucky and we see the area of adhesions where the nerve got injured during surgery. And typically it's not transection. Typically is a stretch injury because they are pulling, down there in the lower pelvic cavity, and they pull the obturator nerve a little bit too much, and that's how it gets damaged. 61-year-old started post-prostatectomy, exactly the same. I'm not going to dwell into this, but that's the typical pattern of distribution of iatrogenic obturator nerve injury. So key factors. The nerve may be injured directly, transected during pelvic surgery, but more commonly it is stretched during prolonged lithotomy position or retraction during THA. And this often resolves, it goes away. The clinical presentation is weakness in hip adduction, sensory loss medial to the knee and the thigh, and typically we don't see any masses. We just see the denervation edema pattern in the adductor musculature. Lateral femoral cutaneous right nerve receives contributions from L2 and L3. It goes under the psoas muscle across the iliacus, and it goes by the inguinal ligament at the ISIS, anterior superior iliac spine, and then it pierces the fascia lata and innervates the lateral, this patch of lateral thigh skin. It's a purely sensory nerve, so there is no motor dysfunction associated with lateral femoral cutaneous neuropathy. It's just pain in that distribution, and we call this Meralgia Paresthetica. Interestingly enough, most of the cases I've seen are in young athletes who have a non-fused anterosuperior iliac spine. They play lacrosse, they play football, they play soccer, so there is a lot of torque motion at the waist, and they get avulsion of the anterosuperior iliac spine, and that causes the entrapment of the lateral femoral cutaneous nerve. I've seen also patients during pregnancy that, this was a mother of twin babies, and the pressure of the weight from the abdomen into the anterosuperior iliac spine caused her Meralgia Paresthetica, which like carrying twins and having Meralgia Paresthetica, the poor thing. And also, some people like to wear very tight belts. If the belt is pressed over the anterosuperior iliac spine, that also can cause Meralgia Paresthetica. All right, so this is one of the cases, lacrosse player in Long Island, where I used to live, and I now live partially too. So the anterosuperior iliac spine got detached from the rest of the iliac bone, and you can see how that effaces the planes about the lateral femoral cutaneous nerve. Just a little bit of word about the pudendal nerve. the pudendal nerve is a little crazy. So you can see here we're tracking the pudendal nerve from its takeoff in the lumbosacral plexus as it goes down into the pelvis. So it changes its mind, it goes back and then it goes anteriorly. It's at this point in Alcock's canal where typically we're going to see entrapment of the pudendal nerve. This is one of those nice reconstructions tracking the pudendal nerve. And this is work that we did with Ronald Adler at NYU, fusing MR and ultrasound to guide injections of the pudendal nerve. This was published in the Journal of Ultrasound about 4 or 5 years ago, if you are interested in reading the article, and it was written by Christopher Burke, who still works at NYU. So pudendal neuropathy, typically entrapment is at Alcock's canal. Cyclists, people who do a lot of biking, may have also entrapment of the nerve against the seat. It gives perineal and genital numbness and incontinence. It's classically worse on sitting. And once we make the diagnosis that there is no denervation edema pattern with this, we just want to find the nerve in Alcock's canal, find the change in caliber and signal intensity there. I find the PSIF coronal sequence very useful, the one that is going through the Alcock's canal. So I zoom my eyes in that location and compare side to side to check for the change in signal intensity. And of course, if you want, you can do a diagnostic injection to help you make the diagnosis. So in conclusion, there are multiple potential etiologies for neurogenic pain. Localization of symptoms as well as knowledge of the neural anatomy are of critical importance in the search for the etiology, and muscle denervation changes are very useful secondary sign of neuropathy, particularly in the absence of a detectable compressive etiology on MRI. Thank you so much for the kind invitation. I hope that you place your questions in the chat room, and I'll be happy to answer those questions offline. Thank you.
Thank you so much. That was such a beautiful lecture. We really, really appreciate it. And it was such great review of anatomy. I think there are a couple questions that Daniel, are you going to lead this?
Yeah, I can lead this. Thank you so much, Dr. Bencardino. Amazing images, great cases. So we have two questions. The first one's from Dr. Arenas. He's asking, can we use Dixon for fat suppression?
Yes, of course, yes. It can be used. It is not included in my protocol. I continue to do this, we get used to the way things look in our protocols, and we get confident, on the way that we assess the images. So I don't use Dixon, but of course, if anyone wants to use it, they are welcome to use it.
Okay, thank you. And the second question is from Dr. Minero. He's asking, which is the role, what's the role for ultrasound imaging, and do you recommend to use this modality?
So I am shadowing Dr. Angie Greenfield, who is my director of ultrasound at Penn, and she finds the pudendal nerve under ultrasound. I don't know if I'm going to get there one day, but yes, there are people who can do this under ultrasound. Believe me, I've seen it with my own eyes. I'm like, what is she doing there? But she and the patients respond.
I feel your pain. Yeah.
Yes.
I had a question about the magic angle effect on nerve signal, and I just wonder if you have any comments on that in terms of the sciatic nerve.
Yeah, the sciatic nerve, I don't see much problems except except when it goes through through the inferior portion of the piriformis. It has that little bend there as it goes by the gemelli. So we have to be very careful. I think we need to pair the signal change with caliber change. And it depends on the stage of entrapment. So if it's very early on, the patient may only have the signal change, not the caliber change yet. So I think in those cases, it's very important to grab the phone and ask the referrer if this makes sense for, sciatic nerve entrapment. Don't just, I wouldn't make the diagnosis without making the phone call. Yeah.
Beautiful. Well, I just want to thank you on behalf of all of the folks who are on the call here for Health for the World. Thank you very much for sharing your knowledge with people around the world. And I do know that you have to get going, so I just want to thank you so much for your time and all your contributions to the health of people around the world.
Thank you, Dr. Dillon. That's what we are for here.
Exactly. And it's people like you that make it really worthwhile. Thank you so much.
You're welcome. Bye-bye.
Thank you, Doc.
Bye-bye.
Thank you, Dr. Dillon. Bye-bye.
Thank you, Daniel. And bye-bye to everybody.